evening, and thank you for being here as we talk about the novel coronavirus. I wanted to spare the time that it takes to give formal introductions as far as my background, etc. So we'll just jump right into it if you don't mind. Just for the sake of understanding, my name is Dr. Oscar Alleyne. I'm the Chief Program Officer for the National Association of County and City Health Officials. That is the national organization that represents the 3,000 county and city health departments across the country. I'm principally responsible for the gamut of public health responses, in addition to being a local advocate national advocate for local public health. Previous to that, I spent 16 years as the Director of Epidemiology and Public Health Planning for Rockland County Health Department, with a primary responsibility of tracking all disease outbreaks and investigations in that county, as well as trying to make improvements as far as the health and safety of the community in which we serve. I was also the past president of the New York State Public Health Association, as well as the past chair of the American Public Health Association's epidemiology section. So that's all to say is that at least I have some idea of what I'm speaking about, but I will be very clear on areas that are not certain, that I will not put myself off as being a know-it-all. So thank you for at least indulging this opportunity. So the first thing that I wanted to discuss when we speak about coronavirus is first trying to address several myths or at least common or misunderstandings. What is a coronavirus? It is named after a virus that has a crown-like spike on its surface, but we recognize that there are 4 main subgroupings of coronaviruses: alpha, beta, gamma, and delta. You don't need to know all of that. That's the scientists in me always having to give more details than necessary. But what is important is that we recognize that there are human coronaviruses and that there are animal coronaviruses. So what is different about this particular coronavirus is it is a new, novel, we would say, coronavirus in comparison to the ones that we know that have existed since the 1960s, or have at least been identified. The common coronaviruses that we do know, starting from the mid-60s, were 2290, which is alpha, NL63, OC43, and HKU1. These are common coronaviruses that we know and have seen around for the test of time, for lack of a better word. Now, there are other coronaviruses that within the last 10 or so years have actually developed and, as we would say, become new to our understanding. In particular, we find the MERS coronavirus, which is a beta coronavirus that was the result of the Middle East respiratory syndrome that we saw a couple years ago. And the reason we were able to identify that, and one of the reasons or the sources of it, it was an exposure from an animal, camel, which exposed to the human population and therefore spread. So that is something that we in the epidemiology world call epizootic, where you're able to go from an animal to a human transfer, and as a result, you then have human to human. So the other is the SARS-CoV. If anyone remembers SARS, it was an international outbreak as well, and that was the exposure between a corvid cat and a human population, which then spread into our human world. So for lack of a better word, you have 2 examples at least of an animal scenario where the animal coronavirus jumped into the human world and became established as a human coronavirus. Now, our most recent one, as within the last 4 months or so, is the current coronavirus 19, or what is called SARS-CoV-2, or it's known as novel coronavirus 2019, or COVID. So that's just to let you understand, and I recognize that oftentimes people hear coronavirus, and whether it's social media or other folks say, well, wait a minute, what's so new about this? It never existed, or there's something on the back of a Lysol can that said it kills coronavirus, so what's so new about it? So I wanted to make sure I let you understand that there's 7 human coronaviruses that exist, and the one that we're most concerned about this evening, and as we've seen in the news, is the latest one, which is coronavirus 19, or COVID-19. Additionally, I have to provide somewhat of definitions. And as I said, being a public health scientist, oftentimes we find that when you hear things in the news or you read things, that oftentimes when you're not trained to that extent of what they mean, it's often easy to make mistakes or make misuse of those terms. An outbreak is any disease that is in excess of what we normally expect. And I say that because in every local health department on a daily basis, on a weekly basis, there are 70 reportable diseases that health departments are responsible for tracking, tracing, and trying to keep a handle on so that we don't see a large amount of disease in the populations in which you live. So those things could be simple as E. coli 157. Well, that's not so simple because you want to jump up for that one. You know, measles, which you heard in the news recently as of last year. But something as simple as hepatitis B, A, and of course we have the other concerns, the STDs, the sexually transmitted diseases, and other foodborne illnesses. So what happens, you will find that you can have an outbreak of disease in a population, and you know it's an outbreak because it's really more than what you anticipate, more than what you would expect, based on your history of what disease exists within your current community. The next is epidemic. And an epidemic is, once again, more than a normal number of cases of an illness that is specific to a behavior or an event or a condition in a community. So you move from an outbreak, which is technically 2 or more, to much more sustained spread of disease, which we would use the term epidemic. In fact, epidemiology is the study of epidemics and identifying ways of preventing their illness and their spread. Oftentimes people confuse that with dermatology or epidermis, and a lot of people think I'm a skin doctor. So I want to make sure I clear up that misconception. The third piece is a pandemic. And that is important because today we know the World Health Organization made an official declaration that this COVID-19 meets the standards for a pandemic. And a pandemic is essentially the worldwide spread of a new disease, of which there's little or no immunity. And the reason we're able to see that, if you think about COVID-19, it has spread from China and moved to several other continents, in fact, every continent with the exception of Antarctica. And we also recognize that there isn't a vaccine and there's no necessarily treatment for it at this present moment. So it took a long time, but there are a number of us that have been breathing a sigh of relief that finally the definition of a pandemic is provided against this particular disease. The problem, however, is that we want to make sure that the general public understands and don't misuse that term pandemic. Pandemic doesn't mean that we're all going to die, head for the hills, and take all the toilet paper. What it really means is that you have a disease that has a potential to cause an impact on our overall health and safety. And just recognizing that the coronavirus 19 is not a death sentence. Yes, and I will explain there are others who are at high risk, etc. But in reality, when you hear the terms pandemic or you play the video games and social that you think the death and destruction of the world, that's not the case. And as we've seen, we've had previous pandemics before. Influenza was a pandemic, and yes, the Spanish flu did kill a lot of people, but we have seen pandemics occur in one way, shape, or form in the history of humanity. So with that said, when you look at the picture, the global summary of where we are with this coronavirus 19, it was first detected in China, and of course there were several steps taken to try to address those concerns. But we've seen it now spread across across the world, for lack of a better word. There are over 118,000 deaths and cases, which 4,600 of those are relatively new. A total of 4,000 plus deaths, 280 of those are new. But within China, we see that 80,000 are confirmed cases, with 3,000 of the deaths associated with the illness as it presented itself in China. And outside of China, we see that there are over 13 countries, which have roughly about a third of the deaths, and roughly about 37,000 confirmed cases, of which for roughly 4,600 of them are relatively new as of today. Now, I will tell you, these numbers probably were outdated the moment I typed them onto this slide because things are continuing to be addressed and reported. But as we look now stateside in our country, We see that now the virus has essentially been established in several parts of our particular United States and territories. In fact, we've seen roughly about 1,000 or trusted over 1,000 cases in about 38 to 40 states, including DC and some territories, and of course 29 deaths. Now, when you hear these cases being described to you, recognize that they come from two primary areas. Travel-related cases, meaning individuals who were in places that had established illness, and therefore, when they traveled back or when they're brought back, essentially developed illness, or individuals who were what we would call close contacts, family, friends, someone that in the workplace, someone that they interacted with, and as a result, they in turn received or had got infected. And then we have the cases of person-to-person spread. Now, you may ask, well, what is different about that in travel-related cases? The travel-related cases, we can always track back to an individual who came from somewhere else or who traveled somewhere else. The person-to-person spread is of importance to us in public health because that tells us that the virus is actually spreading and connected to individuals that actually have no travel history. And that's why you see there's a greater degree of concern from the public health authorities when we see and we found the cases where there are individuals that became ill who had zero travel history or did not have contact with an individual who had COVID-19. Now, part of this additional conversation, I must also mention the cases that we found from individuals that were repatriated back to the U.S. and individuals who were associated with the cruise ships. Predominantly of the individuals that were positive from repatriations, we found that there are roughly about 51 or so that have been identified. And of course, this is a result of people being brought back and ensured that, at least as Americans, we were able to take care of them and provide them with the necessary medication or treatment, I should say. Now, all that said, we're in New York. So your probably next question is, well, I understand what's happening worldwide, I understand what's happening in the US, but how does this impact me here in this great state? In New York, we have a total of 216 cases. In Westchester County, which has by far the most number of cases, they have 121. Nassau County has about 28. Suffolk has 6. Rockland County has 6. Saratoga, 2, and Ulster County, 1. And those are the states outside of New York City. In New York City, they've identified roughly about 52 individuals who have tested positive. Now, why is that important? Now, you may say, well, Dr. Alleyne, these cases mean that we're in trouble, we should run for the hills and go buy that toilet paper, right? In actuality, the concern that we have is how are these particular tests, how are these cases really, how did they start, how did they begin, and what are the connection points? What we have found, especially in the Westchester detail, was that one individual was infected, and in turn, I believe we identified roughly about 50 or so people who, in turn, had close contact with him and therefore became infected themselves. And likewise, there were several individuals that came back from other parts of the world and presented with illness, as we've seen in New York City and other places. So the reality is this, and this is where I think it is important to be conscientious and understand how these diseases work. We anticipate that this illness, this virus, will spread throughout our population. Now, I'm not saying this to be alarmist. What I'm saying is, as a realist, looking at how the illness spreads, on top of the fact that we are in the second cycle of what we call our second flu season, in addition to high rates of respiratory diseases that existed before novel coronavirus, we anticipate that we are in an environment that will permit this illness to continue to spread in a rapid fashion. And that's why we see several of these steps that are being taken to at least try to slow it down. And I'll explain those in a minute. One of the other things that has come up in the recent news has been this concern about testing. How do I get access to tests, and why aren't you testing in? There are problems with test kits, etc. I have to explain to the general public something which is important for you to understand. When the virus first presented itself in China, the genomic sequence of the virus was actually distributed to labs across the world. And as a result of that, many of the country labs, especially CDC and et cetera, they were able to develop tests to try to identify whether or not the illness had made its way into their particular borders. So the CDC was able to develop a test to identify the presence of this disease, this virus, in what we call a diagnostic test kit that was made available primarily through their efforts to individuals to be diagnosed with coronavirus 19. Now, what did that mean? What does that mean? If you had presented, or if an individual came at the first definition of what we call a person under investigation or a person at risk for this illness, you would have had a specimen collected, and that would have been submitted to the CDC, so it had to be shipped down to the CDC for their testing. And then you had to wait for the results, which usually take around 48 hours. Now, as you can see here, from January all the way up to March, those tests that the CDC performed were roughly about 3,698. Then we had a second wave of testing that was pushed out to the state and public health laboratories. And we found that there were roughly about 78 state and local public health labs, meaning the city labs, the state public health labs, who had the ability to use that CDC test to at least provide a second phase of support for identification of individuals that we felt would have been individuals who had been high risk for this disease that we needed to diagnose. So as a result, we found that now those public health labs were able to support the CDC labs by an additional 4,856 tests. Now, what does that all mean in layperson's terms? If you're ill, and if you meet the definition of illness as it has changed over the course of time, the test would either have to be done at a state public health lab, so your doctor, the hospital, would have to speak to a state and local health official who in turn will ensure that that individual can meet the guidance for testing and the test therefore being performed. Now, that is different than if you are a sick individual and you go into an urgent care center or your doctor's office and say, I want to be tested. Those things were not possible. Why? Because of this important rule. When you have a new test, especially something that's focused on a new disease such as COVID-19, there are certain rules that go into place from a federal perspective. The FDA can provide what is called an emergency use authorization for this specialized test to be used in places where it hadn't been before. So the key focus on doing that is to place those capabilities in the hands of the public health authorities. So the public health labs were the ones who had the primary ability to start to do those tests, because the primary focus is how can the public health system identify folks, especially those folks that are critical and ill, to get them the information and whether or not they have the illness or not. The second wave of that is to provide the commercial labs like the LabCorp, the Quest, and the other diagnostic labs who service hospitals and individual providers and doctors' offices with the opportunity to develop their own test kits. But they could not use the same emergency use authorization as the public health labs. Now the FDA has provided that chance, and the commercial labs are in fact receiving opportunities to expand their diagnostic test kits so that they too can test individuals. It still does not mean that I can just walk off the street and say, I want to be tested. You still have to meet certain criteria for testing and ensure that, it doesn't necessarily have to be travel only, but that we are not tested worried well, meaning someone who just said, oh, I saw coronavirus on YouTube, I think I got it, let me go get tested. It doesn't work like that. And I think it is important for us to truly understand what are the strengths of diagnostic testing and what are the reasons why you are hearing some concerns in the media and others as it pertains to how folks can be tested. So, what does coronavirus 19 do to you as an individual? It depends. The illness can range from being mild, runny nose, slight congestion, to being severe, even causing death. You can have respiratory failure, etc. In primary terms, you can get a fever, you can have a cough, you can have shortness of breath. Originally, the case definition kind of focused on having developed pneumonia. It's a lower respiratory disease versus that of an upper respiratory, as you would see with flu. So part of this is that you have a range of how these symptoms can impact you as an individual. On top of that, you have individuals who are higher risk for illness, such as those who have an underlying medical condition, such as heart disease, respiratory malfunctions in the past, as well as individuals who are elderly. Now, that is not to say that the young or the young at heart cannot also become ill. In actuality, we have seen scenarios where that has and can occur. But those who are at the most risk are those older individuals that we have seen from the data and from how things are presented, or those individuals who have underlying medical conditions that make them more susceptible to a more severe outcome of this illness. So, with that said, here's where I have to break down this additional slide here, and hopefully you would understand why I say it this way. While there's not widespread circulation in most communities, the immediate risk of coronavirus 19 is considered to be low. And you'll say, whoa, 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 you just showed me 216 people and thousands of people who are we've seen schools closed and etc. I'm not denying that fact, and I'm not trying to whitewash that fact. What I'm saying is, as long as we have not seen a widespread case of circulation, and widespread means something different from an epidemiologist than most folks, you can have what we call a localized spread or a localized scenario where maybe these folks on this side of the room, they have the illness, and it's localized. It's only within their building, their community, their zip code, etc. That's local or focal exposure. Or you can have an entire borough, just to use the terms that we know here, that may have most of all of the cases. Now that becomes a community-sustained spread. Or you can go widespread where everyone in the city has it. So when I use the term you don't have widespread circulation, we're not seeing widespread circulation at this present moment in our communities. Now, as a result of that, the typical exposure risk that you all may have is considered to be low. But that will change depending on how the disease grows and it spreads and everything else, and associated with whatever strategies we in the public health world try to use to minimize its impact. But even though we may say, as a whole, it's low, what we also need to focus on is that there are opportunities for community spread. So those places where we know and we've seen where the positive cases have occurred run the risk and the potential of having an elevated risk of exposure for community spread. Then we also have those healthcare workers. Those are the individuals who are working in the long-term care facilities, the nursing homes, the hospitals. They also run a risk because remember, there is no treatment for this particular illness or this virus. So they run the risk of also being able to become ill or have exposure. So they have an elevated risk. Then you have those close contacts. Those individuals who may be next to a person who may have shared a cab or a Lyft or an Uber, etc., and who may essentially have that opportunity for spread to occur, and they would have an elevated risk. And of course, and we're hoping to change this hopefully soon, the travelers, because while we recognize now that there are several places across the world that have it, and the fact that this community spread, travelers are at high risk, but they're not the only risk of exposure at this present stage of the outbreak. So, I apologize, I'm an epidemiologist, so I'm going to have lots of fancy graphs, but I'll do my best to explain it. This graph tries to address the next point of the conversation around the terms that you've heard called community mitigation. Now, let me back up for a minute. When we see a disease, an outbreak or an outbreak of illness, we rush to identify it, define it, and try our best to stop it, suppress it, contain it. Those are terms that you've heard used in the general public. When we see a disease like this, which has a very rapid progression, and it doesn't have the vaccines or the requisite treatment to allow us to suppress it, we have to find other ways of trying to slow its spread. And what you see here in this graph is where you have a pandemic and the number of cases. If there's no intervention, you would actually find the number of cases would go up until you get to the point where people are exposed and the disease kind of goes what we call a bell curve. It goes up the decline and eventually gets down to a 0 or a low level. Now, the next, the blue sections is when you actually try to introduce community interventions or community mitigation. And what that does, it suppresses the overall effect of the outbreak in your community. So you will have cases, but they will be much lesser than if you had done nothing at all. And I'll explain that in the following graph, which I hope will actually make some sense. The navy blue and red represents Hong Kong. The light blue and yellow represents Italy. And in this, you see a comparison between the number of cases that happened in Hong Kong, both the cases and deaths, in addition to what happened in Italy. And this is a perfect example of how community mitigation works. In Hong Kong, they took aggressive steps to try to minimize the risk of exposure of individuals and suppress the spread of illness as best as they could. And they still got cases, but as you kind of see, their cases kind of level off, kind of remain somewhat parallel. Now in Italy, where they did not have those community mitigation efforts made, and didn't have quite a lot to some extent, we actually see an increase of both cases and deaths. So this attempts to illustrate to you, if you don't provide this community mitigation effort, which is a whole nation type of approach, you can actually end up seeing more cases ravage your communities than not. So, which brings us to what is happening in New Rochelle. In New Rochelle, you've probably seen the news that the National Guard was called. There's now a containment area that is specifically focused on trying to minimize the spread of the illness in that community. And there are several reasons that was done. It is a very aggressive approach, but because we saw 108 of the cases, of the 121 cases, being in New Rochelle, I think the governor, with the advice of the medical professionals, made that determination. And I'm not making a judgment one way or the other. But the goal of that was to try to involve both the faith-based organizations and the healthcare exposures that they saw to identify how they can really reduce the likelihood of further spread in that community while really focusing on those individuals who had higher severe risk of illness, those who had underlying health conditions and immune suppression, and also the healthcare workforce and the critical workforce that's needed, because people still have to go about their daily lives. As we know, New Rochelle is kind of cottage to New York City, so the likelihood of folks being able to come in and out. The whole goal is to try to at least provide a strict measure where individuals who are sick can gain access to care and also ensure that they are not having the movement that can jeopardize the rest of the population. And we will see at the end of the next 30 days how successful that has been in hopefully suppressing the spread of illness in New Rochelle. Now, I'm going to start to talk about a few numbers for a second, just not to bore you, but to give you an example of what is the state of affairs of our public health system. Normally, when you think about emergency preparedness, starting with anthrax, smallpox, monkeypox, and all the various things that you've heard over the course of time, the federal agencies like the CDC and ASPR, which is the Assistant Secretary for Preparedness, they have put out funding to support both local and state health departments and hospitals to be prepared for emergencies like this and others. And the goal of those funded programs was to, one, make sure folks, staff were trained, people had the right personal protection equipment, that they were doing drills and exercises, and they had plans that they could not keep on a shelf, but to exercise to show that they have a sense of preparedness to respond to these types of emergencies. And if you notice, there was a 36% cut in the funds for these particular activities. Whereas we went from 766 to 623 million assigned across the U.S. For these funded activities. So oftentimes what they did, or what the funds were able to provide, was for a state and a local health department to actually fund a person to be able to write plans, exercise plans, and hopefully have the ability to use those plans when something happened. Now, the problem with that is that it only allows you to do the preparedness side of the coin. It does not support you when you have to respond for a long period of time. And I put it in these terms. If you have a blackout, we all know we get inconvenienced, and maybe it may take a day, or maybe an hour or 2 days. The idea is that it's a short-lived period of time when we go without power. So somewhat we can deal with the impacts of that. But when you take it for a sustained effort, like let's take, for example, COVID-19, where you see people need to be monitored for 14 days, there are all these other circumstances, the likelihood is further, and for the folks that have been responding to this illness, it's a sustained activity that has an impact on your workforce. And this is a workforce that already has seen losses over the course of the last 7 years. So the Congress just provided $8.3 billion in emergency funding to support the response to coronavirus. $950 million of that is supposed to go to states and local health departments and localities to monitor, track, provide infection control, deal with community mitigations, etc. Half of that amount is designated to go out within 30 days. So it is the hope that those local jurisdictions who have been working day in and day out to try to support what is needed in response to this illness, that they finally get the funding to not only hire staff, but to get the right equipment and to sustain the effort that's going to take for this long haul. 826 is going to the National Institute of Allergy and Infectious Diseases to develop a vaccine, a cure, and test. Now, as you probably heard from what some of us call our hometown hero, Anthony Fauci, on television, the vaccine is not going to be available in 3 months or 6 months. It will be a year to a year and a half, mainly because of the pathway it takes to create and test the vaccine to ensure that it is not causing a negative outcome or a worse outcome than if you actually got the disease. So first there are animal studies, then there's a phase 1 where there's some human studies which are currently in place in some cases, and then you go to a phase 2 and a phase 3, where basically you're expanding out the population who are being tested for the vaccine to see what are the short-term and long-term effects of that vaccine, and does it in fact truly provide the needed support and defense against future infections. That's not something you want to fast track, and that's not something you want to jeopardize the health and safety. And I say it this way, it's one thing to say that yes, you are concerned about people with coronavirus, but you don't want to treat them with something that all of a sudden now they have coronavirus and plump it. That was a joke. Don't be so serious. So the other piece of funding is $300 million to help buy vaccines and treatments once they become approved, and $136 million to reimburse the work that has been currently put in place. And as I mentioned, when you think about the public health workforce that exists on our states, our cities, and our local entities, we have seen a reduction in that workforce since 2008 by 50,000 jobs across the country. And 55% of those oftentimes are individuals who are much older and ready for retirement. So we're concerned about the brain drain and the opportunity for folks to truly be ready to stand the test of time when it comes to addressing these illnesses. And then when we think about the travel restrictions, as I mentioned, because of international travel and areas that there are now level 3 alerts where we're telling people to avoid unnecessary or non-essential travel to China, Iran, Italy, South Korea. I don't doubt that certain countries may say the same in return for us. But also the idea is that there's a recommendation for folks, especially older individuals of our communities, to please reconsider taking cruise ship voyages. I mean, there's some people that still want to do it, God bless their hearts, but if you see what's happening with cruise ships, just be mindful of that. So maybe tell your folks and friends that really they should reconsider going on cruise ship voyages. So all of that said, And I'm going to just go through these slides quickly because I want to get an opportunity to answer questions and deal and field your questions and concerns. There are clinical guidance that is provided on how to treat and manage individuals who come down with coronavirus. There's environmental cleaning and disinfection recommendations. We know that the virus could be on the surface from a matter of hours to maybe a day or two. So it is important when you are thinking about, well, what can you do? How can you clean the surfaces that you have in your homes or your communities? You know, there's guidance that's available widely for folks to get better information. And please don't just use the social media messages that you see that some guy from the CDC says that, you know, this is what he's done, and, you know, go to your proven individuals and entities that really have done the research on this. Another area that we hear about is the role of the N95 respirators, or I should say the surgical mask. And one of the concerns we have in the healthcare industry is that people are rushing to go buy masks just as much as they were rushing to buy toilet paper, and as a result, it was causing a negative impact on what supplies were available to the healthcare industry, to the point where there's conversations with the mining and the construction and the industrial groups who do also use N95 respirators to see how we can tap into that supply chain, and also, as was mentioned nationally, to ramp up production of these types of equipment to get into the hands of our population, especially those who have to respond and take care of ill individuals. And the question then becomes, well, should you wear a mask or not? When you think about what you see, especially in the Asian countries, the masks are worn for two reasons. One, many of them are in areas that have poor air quality, so the masks are used to really address issues like fog, etc. Then there are those who wear masks to prevent, as we would call, droplets. You sneeze, you cough, you feel you have a cold, to prevent those droplets from being able to reach other individuals. Now, it's totally interesting because in the American culture, we see someone with a mask in the bus or in the hallway or the elevator, we want to run away from them. And ironically, now that has obviously changed because now people want masks and are choosing to wear them even though they're not ill. So our goal is really to say, you do not need to wear a mask as a healthy individual. And recognizing that the spread of illness is not pronounced in our current community or the community in which you may live. In those scenarios where you would need to wear a mask is if you are sick and you are feeling ill and you are on the way to a doctor's office or etc., then you obviously try your best to minimize the exposure to other people, but ultimately keep the mask for the sick people and the healthcare workers as much as possible. And there are lots of guidance that we have on how you can prepare yourself, your family, your community, and more especially if you are at risk of being sick because you're in a higher category. Yes, you should stock up on home supplies, medication, take precautions to separate yourself, social distance from others, try to minimize going out in public, keep away from people who are sick, and wash your hands often. I would dare say that as much as we've been saying over the years you should wash your hands, it's only now, I think, that we've seen how much people have taken up that answer because of the threat of this pandemic. Of course, you want to avoid crowds if you are high risk, and try your best to stay home to reduce the risk of exposure. Or if you have someone like that in your home or community, to be mindful that you yourself, while you may, if you do become ill or you may have a mild illness, your exposure to someone who is high risk can actually have a negative impact on their health. So we have several infographics on what you can do to encourage your family members, you know, the schools, what they can do to prepare, the businesses, employers, how they can implement things such as better sick time, allowing for remote work. Of course, we recognize that there's some industries where that's not going to work. I still have not figured out how to wash dishes remotely, so I don't imagine that we can tell people who are in those service industries that, yeah, you can work remotely to get your job done. So all of these guidance are important to ensure that we at least are practicing good hygiene and we're very careful of how we interact across the communities, especially as we begin to follow this spread of this illness. And the same has been done for healthcare facilities as well as other entities that one may find themselves in, including our Grand Lodge building and other places of that design. So with that, I will say thank you for listening, and I think I will turn it over for us to have conversation, and I can try my best to respond to any questions or concerns that you may have as it pertains to this coronavirus epidemic or pandemic and its impact on our lives moving forward. Thank you.
We have a question from Facebook from Michael Matsis. He wants to know if the test of holding your breath for 10 seconds is a real test.
Not for coronavirus, no. No. It makes room for other things like swimming underwater, but not. You have a question?
Okay. Thank you for this wonderful and informative lecture. I'm a doctor and I have my private practice, and I see patients that might have some symptoms that I might think that may have coronavirus infection. If I have a patient that I'm suspecting might be infected, I use Quest Diagnostic.
Yes.
Should I send the patient to Quest Diagnostic, or referring to a PCP, or what is the recommendation when you encounter somebody?
The current recommendation for healthcare providers at this present moment, if you have a patient that you suspect needs to be tested, you need to be in contact with the local health department. So if you're in New York City, you have to contact the city health department or the state health department to ensure that that individual can at least be tested by the approved test. There is a current strategy to provide the commercial labs with new tests that they can do, such as Quest, etc. They don't have that capacity as of today, but the idea within the next week or so that they will. So the first recommendation that will be provided to individuals like yourself is to get in contact with the city health department or the county health department where your practice is, so that that individual, you can consult with the public health professionals to ensure that your patient, if they meet that definition, can be tested.
Another question. When we see the, I don't know if you have seen the whole genome of this virus that has mutated.
Yes.
It is true that there might be like some sequence that are similar to the HIV, like retrovirus. It's possible that this mutation didn't occur naturally. It might be a manipulation, like a human manipulation.
So there's a lot of conversation about it being manipulated and created in the lab. There's truly no indication that we have to support that, especially seeing how it is one of the coronaviruses that we've seen, and coronavirus, as I mentioned, has existed. The sequence was readily available to be sent out to countries across the world so that they could develop their response. And when you look at SARS and the Middle Eastern Respiratory Syndrome and some of the other coronaviruses that exist, there's stark similarities. So I know there's always going to be individuals who may try to advance a certain perception that this is something that was contrived, but we have no real proof or evidence to support that at this present moment. And we've seen, especially seen the history of other infectious diseases that have jumped from an animal population into the human world. Thank you. Yes, ma'am.
What's the latency period of COVID-19?
So the latency meaning how long does it last? And it depends, of course, on the individual itself and in their response, as I would say, their health-based response. So you have the fact that it takes 14 days for it to grow, develop, and we've seen people rapidly resolve within 30 days or less, and then we've also seen people who have been much longer with illness that have been essentially secondary courses of infection, the pneumonia, and those other elements. So it's a range to that extent. That's why we focus on those 14 days to see whether you develop symptoms and convert from exposure to having disease. You asked a question already, but I want to get to the question. Yes.
For cleaning solutions for the home, the surface cleaning, how effective is Clorox, and what solution, what dilution would you recommend, if it's any good?
So on the CDC webpage, which has the environmental cleaning disinfection recommendations. They actually go through a list of chemicals or disinfectants that meet the EPA standard for these similar types of viruses. So I would always encourage you to take a look at those. I can't rattle off all the lists off the top of my head. I'm not that good, but they are a list of several EPA approved and other described disinfectants that you can use to clean surfaces. And that's easily available. You can just use this list of environmental cleaning disinfection recommendations as a search for CDC, and it'll pop up. Yes, sir.
I know we don't have a ton of information, but as far as you can tell, how different is this compared to the regular flu if we didn't have already immunity to it? Because I understand since we don't have immunity to it, it seems more serious. But in terms of, you mentioned latency periods, in terms of being a carrier without like how sick people are getting, it seems, at least from the news, that it seems like people are carriers without having any symptoms at all, which is a little unusual. And it also seems that people are getting, even younger people that would normally just shake off the flu seem to be getting a lot more sick with this. I'm wondering why.
So the first portion of the question is in comparison to the flu. And in the U.S., we recognize that flu infects a lot more people than at present with coronavirus. And flu oftentimes kills 20,000 people a given year. The difference, of course, we have a vaccine for influenza, but people don't seem to want to take the vaccines. And as a result, the comparison between flu and coronavirus ends where you identify that there's a presence of a vaccine and there's also what we call treatment options. You can treat with Tamiflu, Oseltamivir, and all these other, or Lenza, and these other treatment options. The same does not exist for coronavirus. They're currently trying to explore what types of responses they can get out of certain treatment styles, but in particular, as compared to flu, such does not exist. So then the next question comes up, well, if more people die of the flu, then why are we jumping up and down over this particular illness? It is the fact that there isn't an immunity, or I should say, a pronounced immunity that we know of, the fact that it is novel, and we've seen in rapid progression. As I mentioned, the impacts for influenza being upper respiratory versus lower respiratory that we've seen with coronavirus does show a little difference in that regard. But specifically, what we tell people, because we're in the second cycle of the flu season and other respiratory diseases, we should be worried about all types of infection that can cause a negative impact on our population. And to your other component about saying individual or asking about those individuals who are younger and seem to be wiped out, which is used common terms. Just because you're younger doesn't mean that you will have a mild case. We have seen individuals who have been one-offs or two-offs where they're relatively healthy and unbeknownst to them, they've had a very negative response or reaction to it. And there are others who have had basically symptoms that were probably undetected. And which goes to your third question around this concept of being asymptomatic spreader. And that term basically means that you have zero symptoms, but you are growing the virus in your body and you're able to spread it to people while you show the symptoms. From the preliminary data that we've seen, even those individuals who we can say look like they're asymptomatic, they actually did have some form of illness, even if it was a mild illness, while they were shedding. So the concern around asymptomatic spreading is one that we're constantly keeping our eyes and ears open towards. But in reality, of the cases that we have seen and the data that has been collected thus far, things can change tomorrow. The individuals who seem to be asymptomatic did have some mild or other symptom that they would not have categorized as really being ill per se, and that's how we've seen some of the extension of that spread. You have to follow up that question.
I do. I'm just kind of scared that I just thought of it as you're describing that. Based on your knowledge of where things are, what's the likelihood that anyone in this room has exposed to the coronavirus?
There is always a likelihood that someone in this room or anywhere in the subway, etc., may be exposed to coronavirus. The question now becomes, where did that exposure come from? So as an epidemiologist, I would ask, are there individuals here who may have been connected to someone who had recent travel history, who may have been sick, who may have been associated with any of the current cases that we currently see? Because we do not know the extent of the community spread, as I said before, our best faith estimate is that at the current state, the risk is low. So we can be in these rooms, we can have the conversations as well as later, etc. But there's always a likelihood that I cannot say does not exist. Yes?
Thank you for a very comprehensive talk. The incidence numbers that you had in your first couple of slides, are those the confirmed cases where the actual genome has been reviewed? And if so, what happens to the people that go to university departments or other providers that, based on their symptoms, quarantine the patient for 2 weeks or 1 week or whatever length? Do you think that the numbers that the CDC is actually documented is underreporting the actual incidence of cases? And if so, what is the community's ethical responsibility to do, and how do we behave in the setting where we go, we have these symptoms, we don't have the genome actually tested, we're not diagnosed with it, but we're manifesting the symptoms? What is the responsibility of our coworkers? So how should we as a community respond in a setting where we don't readily have access to testing, but at the same time are faced with this real threat?
Sure. Excellent question. So the cases that I reported, especially for the U.S. cases, are confirmed and presumptive cases, meaning they're ones that have been totally laboratory confirmed by CDC, and presumptive those that were in the first stage, the state or public health lab have tested them, and they're requiring a secondary confirmation from the CDC. So that's first. It's inclusive of that. The other component of your question is one that has, and that's why I went through the discussion of what those tests mean and how we get tested. There is a balance that you will need to have as far as who gets tested and how. And the risk that does exist for individuals who may be symptomatic but may not, as we've seen in a couple of cases, that they did not meet a strict case definition and therefore they were missed. And how are we able to identify, are there more people like that in our community? You will essentially have to make the judgment that they are. That every case that's reported, recognizing that one individual can theoretically infect 2 or 3 others. The idea is that we will probably see, and that's why you hear the terms as inevitable used, that this illness and this virus will spread throughout our country. It is inevitable that people will be exposed. Where you ask the question around the ethics, I think my best answer to that has been what I call that social compact, that social responsibility that we as a whole nation community are not only focused on, well, the test is the only way I can determine my illness, but that I can take whatever necessary steps. If I am ill, stay home, do not go to work, do not infect other people, communicate, and of course, make the case for speaking with your healthcare provider to identify and at least ensure that the proper treatment or the proper responses are done for these types of community spread. You know, there's this phase that we have to go through as public health professionals where we want to try to get every last case that we can identify in the first stages. But then you're going to reach that threshold where we know that you're not going to be able to track or test everyone. Meaning, it now has become, as I use the term, widespread. So you will have to shift from focusing on testing to focusing on community mitigation. And that's where you see there's some communities that have already moved to community mitigation, while some are focused on testing for the goal of trying to contain or minimize or at least identify. So when I speak about the social compact, the social responsibility is where we now have those discussions what can you do as a community, as a family, as an individual, as an organization, to take the necessary steps to minimize your own risk and the risk to others around you. And that's where we always ensure, or say, encourage people to develop a community or a family plan, a family emergency plan. You know, develop your supplies. You have a conversation with your family members who may be sick or infirmed or maybe at a higher risk. You know, I paint this picture, if I can use it in this best analogy. When I was the epidemiologist for Rockland County, my population that I served was 312,000 people. I was one epidemiologist. There were roughly about 150 staff members in the health department. So you have 150 people trying to take care or stop the spread of illness for a population of 312. Those resources or those capabilities will be taxed with a widespread outbreak, correct? So the component of that social responsibility is how can you work with community-based organizations, healthcare entities, faith-based organizations, groups such like the Masons, etc., to really get the message out that we should have a better opportunity to really focus on not only what those 150 people can do, but how can we expand our network that everyone takes a responsibility and a role in trying to help mitigate the spread. So that's my best answer. It's not going to be perfect, but that's the way we at least are approaching the concern at this present moment. I'm going to need some help with my moderating. Jeb in the back.
As opposed to flu vaccines, people that don't take flu vaccines, spoke about vaccines earlier. What can one do as far as natural or holistic things to build their immunity, their body immunity to guard against these viruses? One. Two. How did they come up with the name coronavirus? Because when I think of corona, I think of the sun. And are there certain temperatures or degrees Celsius that these viruses can exist in and live in?
Okay. So first, there are not recommendations that I can have around holistic or other non-therapeutic solutions for boosting the immune system. Mainly because, as we recognize, because this is a new disease or new virus, there isn't much that we can identify that would say, do this and it will prevent you from being infected or succumbing to its illness. It's just not something that we have seen or that we can recommend. I mean, if folks want to try any elixirs, etc., by all means, have at it, but don't have a false sense of security that that's going to protect you from the spread of this illness. Secondly, the question around the coronavirus. In the first slide I mentioned, they're called coronavirus because of the crown-like spikes that are on the surface of the virus. So if you see those images of the coronavirus, even similar to what you see in my bow tie, because you have those spikes on it and they are shaped like a crown, therefore the corona, that is where the term comes from and why they're called as such. And forgive me, there was a third question I had, and I may have missed it. Did I catch it?
As far as them living in certain temperatures.
So the idea is that there are certain times, as you would even see using the example of flu, where flu tends to be most active, and these types of common colds, etc., are most active when you're in a temperate region, goes to fall, summer, spring, etc., and die off into or go into remission in the summer months. So there's some expectation, or I should say hope, that we will see that, but we also recognize that in of itself isn't something you should take to the bank, mainly because we've seen the cases also occur in the temperate and the tropical climates like the Caribbean. In fact, Jamaica and a few other places were identified as having the coronavirus in their communities as we speak. So the idea is, of course, the virus itself, extreme heat will inactivate it, etc. So there is that possibility, that expectation. But it is so new, we cannot say anything other than what we know of other coronaviruses and base our good faith estimate on that. We will have to see what transpires as this outbreak continues. Yes, sir.
Question. You're in the transportation business, for instance, cargo, and there's an individual that's infected with coronavirus, coughs on a piece of cardboard, for instance, how long would that virus be able to sustain life before it would die without human culture?
So we've seen the virus have what we call viability for a number of hours to even a day or two. That has been shown and proven in certain substances or certain surfaces, and that's why the disinfection of surfaces is something that we always try to encourage. But however, it doesn't mean that if you get a shipment of something from China that makes it from China that you will have the virus on it because it's not going to survive that long of a journey.
So it's a matter of hours to a day.
Correct.
I have two more questions coming from Facebook. The first is from Brother Daniel Silverman. Do you expect the mortality rate to be at the same as the common flu as the spread of the virus peaks?
So one of the problems in using epi-terms in the general public is that they give a false understanding of what they mean. So, for example, the questions about mortality rate. How many people die? Then there's case fatality rate. How many people are dying based on cases? Then there's the R naught, which you've probably heard watching the news, etc., which is the reproducibility, how many people that can be infected. Then you have an infectivity rate. So the bottom line to the question, however, is because this illness is new, we can't even, based on what we saw in China, as an expectation what we will see here. We can only identify based on our combination of community mitigation and case detection that would allow us to have a better idea as to what those fatalities or those deaths would be associated with coronavirus. So they may go up, they may remain constant, or they may subside. I mean, right now, as I mentioned, we have in the US 29 deaths. We expect there to be more. I don't know how many more it would be, but we have a very large population, and we can only see how long this illness continues, and at the end of it, the impact that it has left on those individuals, unfortunately, who may pass away.
Okay, and Worshipful Anthony Walsh says, I'm on state active duty in New York assisting with quarantine and transportation. In a quarantine area, are the risks higher to contract the disease even with seasonal allergies, or should I just remain with universal precautions?
So what is recommended in his particular scenario is probably three things: universal contact and droplet precautions. Especially seeing that he has asthma or related respiratory illness and being in an area, I don't know exactly where. Obviously, any type of quarantine zone, they would try to keep a line of defense away from individuals themselves. But if he ever has direct contact with individuals that are either under investigation or ill, therefore what is recommended for healthcare professionals or those who are in those particular scenarios will be the combination of those three.
Excellent.
Yes, ma'am. Trust me, I'll get a promise. Yes, ma'am.
Thank you so much. I wanted to ask you, it's hard to predict this, but do you think there will be any long-term complications, complications for people who recover? Because we are talking about number of deaths, but we don't really know what happens to people who recover, and they will have long-term lung damage, what might lead to that.
It's an excellent question. For what we have seen, there have been instances of some long-term concerns, specifically to scarring in the lung tissue as it pertains to the impact of pneumonia, and whether or not that in of itself causes long-standing impacts down an individual's life. So they develop pneumonia, there's some scarring within the lung tissue, even after they've resolved from pneumonia, and does that put them at higher risk for other respiratory diseases? And also recognize it's still new. We're still within 4 months of this illness really being identified and tracked and traced. So the long-term implications are not going to be seen until later on. And at this stage at best, we're trying our best to keep an eye in air as far as what we need to detect and what we need to pay attention to, not only in the response, but in the recovery phase. And to your point as well, as you probably have seen in the news, there are more individuals that are actually resolving from these illnesses than those that are dying. And I think we've turned that corner for several reasons, but hopefully it points us to the reality that this, like SARS, may be something that will be endemic, meaning it's actually here to stay, and that's something that we hopefully can work around towards the future.
Thank you. And a personal question. If you were a person who's immunocompromised in this coronavirus universe, where would you feel the safest in the United States?
That's a tough question.
Like you obviously need access to a good
You need to be able to gain access to your health care if in fact you become exposed or you have concerns and signs and symptoms. Some location where you can be safe, have a clean environment, reduce the likelihood of interaction with others, but also that you can easily and quickly get to a healthcare professional if in fact you become symptomatic or exposed.
And with high temperature, be a big, failure if you can safely make it.
Correct. And that's one of the reasons why we actually, the recommendations are, if you feel ill, don't just show up at the doctor's office. You actually call, contact them, and get some direction, because if you think about this illness being so new, and the fact that person-to-person spread, as we saw in the long-term care facilities, many of the older folks that succumbed started to present like almost, it was like they basically, quote-unquote, tagged in an hour. So you want to make sure that you have that access, but that you also don't run the risk of exposing others. Much like the Uber driver who is now one of the cases that we see because he transported someone to a destination and ended up being ill. So I hope I answered the question.
I thought the question referred to the last question about temperature, whether it's a higher temperature would be better or not.
Oh, I did answer the question. I said.
Oh, okay.
Oh, I'm sorry.
All right, I didn't hear.
Well, he had asked the question before. So high temperatures can inactivate the particular virus, but this virus itself, the point I was making, we've seen it in temperate and tropical climates as well. So it still remains to be seen, and as the illness continues, whether the change in temperature has a negative impact on its progression, coming up. At this present moment, we don't know. We can only surmise based on what other viruses like this have acted. Thank you. Yes, sir.
So in the media, at least, there have been a lot of comparisons to the Spanish flu from roughly 100 years ago. Not just because of the fact that it's a flu, but because people are drawing parallels with rates of mortality and what have you. There's a concern amongst a group of people that we may see the virus die down in the summer and then re-emerge in the fall. So, in your opinion, do you think it's important for us to keep these precautions of washing hands and being preventative measures in general through the summertime?
I am an opponent of always washing my hands, not only. And I can tell you, people say, well, you're probably one of those germaphobes, and in reality, what gets me is when I go to like a public health conference or I go to a medical conference and I see folks using the bathroom not washing their hands, and it just keeps me out. So when you think about it, a lot of the diseases that we have and the illnesses that we've seen, whether they're foodborne, diseases that can be stopped by immunizations, etc., a lot of them can be stopped if people just wash their darn hands and just practice what we call basic infection control. So yes, not just wash your hands now because coronavirus is a threat. And if it may subside in the summer, go back to just being carefree, etc. But wash your hands constantly in the sense of making sure that you are in an environment that does not allow us to spread illnesses undeservedly. And the other thing I want to mention, which is an additional concern for us in the public health world, yes, there's also a recommendation to use hand sanitizers, but you really want to use hand sanitizers when you don't have ready and easy access to soap and water. The reason why is when you think about the overuse utilization of hand sanitizers, you can essentially also add to the problem that we've had growing in this country for the last 10 or so years, which is antimicrobial resistance. And you don't want to basically train other bacteria and viruses how to be resistant against these types of these antibacterial treatments with the hand sanitizer. So please, if you can get to soap and water, do that first. If you absolutely cannot, then be liberal with your use of hand sanitizers, though we are recommending that they are available with respect to this current situation. You had a question.
Yes, since it's a new, we have said that it's a new virus, that's something that has never been seen before. One part of the question is, I think it was asked already, do we expect this to be a yearly occurrence? And two, if I make an example of staying in front of a TV screen and watching everything that the pharmaceutical industry is running on, including built to last a little less. What are they doing? Is there a research push in finding a solution or some type of a solution?
So we don't know how long this will last and whether or not it may go away and come back for research. We're not sure. So we can only base our information on what we've seen other coronaviruses and other viruses like this do. So at this present moment, it is an all-hands-on-deck approach, meaning that we do our best to try to minimize its impact now, and two, as long as we can bring it to the downward trend of that curve. But also, don't be lulled into a false sense of security that this will happen again. And this is where we anticipate that the virus will spread throughout our communities. You will have individuals exposed, much like when West Nile hit us in 1999. That never existed in the U.S. Now we see West Nile is here to stay. Similar with Lyme disease. Lyme disease is endemic in this region. It hadn't existed before. Now we see it being part and parcel of our activities. Same thing with H1N1. So the point is that as these types of incidents and these events happen, there may be a scenario where they become endemic, they become part and parcel of what we experience, and we may have vaccines to help fight them in the future. But at this present moment, we are in a space where we don't have much to go on, but we do know that there's been active work to try to not only identify what can help now and what can be developed in the future. So there are some pharmaceutical companies working on vaccines, not just one. There are others that are looking at the therapies that may be helpful in trying to analyze the data of where people are sick, where people are really succumbing, and where people have actually resolved quite easily to figure out what are some strategies that we can then use here in our country and recommend across the world. Whether it's the World Health Organization, European CDC, our CDC, there are several entities that are working day and night to try to learn more about this and, of course, try to advance the science and how of our humanity. Yes, sir.
Yeah, so I got a community, transmission mitigation question, but I'm just a little curious first. Has New York City added any ICU beds, or do you have any data on that, or how many available ICU beds do we have in New York City?
So the hospital prevention program has been focused on identifying what are available beds, and actually the feds and others have been trying to create modeling that address the bed access and what's going to be critical for both treatment of individuals who may be ill with this coronavirus, in addition to others who have other issues that they will have to contend with. So I don't have that number off the top of my head, but there are reports that are available under the Hospital Preparedness Program, and as well as the Health and Hospitals system that talks about how they are prepared and what they have been doing to examine bed access and bed availability. So also recognize one thing that I neglected to say, while everything in the news seems to be around coronavirus 2019, the other diseases aren't sitting by saying, oh, we'll just wait our turn, right? We'll just hang out, let coronavirus have its thing. Especially the concern around those who are on dialysis, those who have chronic conditions, the ICU beds are not just needed only for coronavirus. So the idea is making sure that we're at a capacity that can either ensure that there's a phase of defense or at least access to those opportunities if in fact things get worse. But how do we also balance that against our current needs, especially in this area, which is a very highly population dense city and metropolitan area.
All right. So you don't know.
You can't just add an ICU bed.
You can't add an ICU.
You're not when you think about how hospitals are organized and the access to the beds that they have developed for provision of care, it's not as simple as just saying we're just going to throw in an extra ICU bed. You're going to look at what, for the normal operation of the hospital, what is necessary and what beds they currently have per their population that they have to serve. And what ramp up, meaning what available beds they can make, meaning moving folks from maybe within a hospitalized setting to a long-term care setting and making beds available. It's not just rolling out of bed and saying, we've now added 10 or 50 more. So there is that I really want to make sure that I articulate with respect to your question.
Yeah, because I came to find out today in LaGuardia they added 500 and then they were filled up. So you mentioned community mitigation and you talked about Hong Kong, and some people are saying that South Korea is really sort of the gold standard of how to mitigate. They're doing very aggressive testing, they're doing very aggressive contact tracing, they're doing very aggressive quarantining, and they also require everybody to wear a mask when you go out in public. That's why they have a flat curve. We seem to be following the Italian method, and we are actually tracking their exponential curve, lagging by about 10 days. What is your explanation for why we are not following what appears to be working in places like Hong Kong and South Korea?
So the example that I illustrated was the effective community mitigation, not an attempt to do a description or a comparative analysis between Hong Kong and Korea. It was just an example to illustrate how Italy, by not providing or having the opportunity to be as prepared as possible, had a more positive rate of cases in Hong Kong. By their community mitigation efforts, were able to show a parallel. So I just want to make sure I clarify that. And as far as the question as to what the U.S. is doing, the public health professionals have been really doing a lot with respect to not only activation at the federal, national, and local level, but they're doing their darnest to ensure that we have a system in place to address the needs of our community. Now, I know there are several that would have criticisms over the national stance, and I'm not here to represent the national stance. What I do speak to are those local public health professionals who, as I visited with this weekend, are sleeping on desks because they're out there not only trying to identify close contacts, but essentially ensure that there are wraparound services available for those individuals, to ensure that there's clean, disinfected communities, and that they're talking to their communities and the businesses, et cetera, as to what everyone can do collaboratively to help address this growing issue. So I can't speak to any form of policy or comparative analysis between South Korea and what the Americans doing. I can only speak to those, both those state and local, and especially the local large, medium, and small rural health communities that are taxed and are doing their best to ensure that they do to protect and provide a line of defense for the impact of this coronavirus. Yes, sir.
About the people that use national transit, where you have millions of people, a large number of people from all walks of life that come onto the train, and you're in tight quarters. How worried should we be?
So, once again, I would say it's dependent on the rate of transmission in the community, which you can argue, well, you don't know because we haven't tested everybody. So there will come a point in time where you see widespread transmission where there would be impacts on mass transit. At this present moment, individuals are free to do as they wish, meaning if you are taking mass transit and you cannot minimize your exposure to doing that because that's the only way of transportation, try to find ways to hopefully minimize your risk of exposure if that is, of course, the primary concern. I've seen people wear gloves on the train. Some people wear masks. We are not, as a public health entity, recommending that. But if it does at least provide a sense of comfort and at least an active role by which you are taking charge of how you look and minimize your exposure, then you do what is necessary to at least make sure you do it as safely and as with the proper disinfection and disposal as possible. I say that because I saw a young lady today with the train. She had a glove, and she put the glove on to hold the cart, to hold the strap, the pole, and then when she got off, she took the glove off and put it in her pocket. That's not disinfection. You just polluted your pocket because you're going to stick your hand back in your pocket and put the glove back on. So think common sense, dispose and minimize your exposure. But there may come a point in time, and we're not there just yet, but there may come a point in time where recommendations to either slow down or use or risk of exposure to mass transit will be something that the authorities will mention. Yes?
As far as the recommendation for the self-quarantine, sounds really easy if you live by yourself. But for those of us who have young children, for people who may take care of elderly parents or relatives, what is the practical solution there? You live in close quarters with multiple other humans. My job doesn't allow me to work from home. It's not a thing that I can do. I'm out in the world, I'm exposed to people, and then I come home and I've got a 2-year-old. Is there a specific procedure that might be more or less effective as far as guarding the health of the people you live with, or guarding your own health if you're the one in the vulnerable position and you live with someone who has broader exposure than you personally could sustain?
Sure. And you actually raised a secondary interesting point that I want to address, the concept of quarantine. And quarantine, once again, is one of those terms that people use, and they seem familiar, but they may mean different things. So primarily, and I'm going to answer your question, but I want to, hit a couple of other areas. When you heard folks who were coming from other countries or folks that were placed under quarantine or quarantine orders, they were essentially confined to a location to ensure that the period of time kept them away from others. So in the case of the foreign travel, they were quarantined in a particular scenario, like the cruise ships. Some were quarantined on cruise ships, or some were flown in and placed into a defense facility. So that's quarantine. Then there's self-monitoring, or staying at home and self-monitoring. I get my point. I'm not trying to be pedantic or semantic. The home isolation is essentially, you may have had a medium to low risk of exposure, or you would at least try to make sure that until you can track and know whether or not you actually turn into a full symptom or case, that 14 days, you essentially monitor your health, minimize your risk by making sure you're not exposed to others. To the example that you painted, the recommendation would be as much as what we would say in an environmental exposure. When you go into the home, try to have a clean space where you can take off your clothing, etc. Separate them out just for the sake of if by chance you may be in a scenario where you are introducing the virus on your clothing, etc. You try to at least have a system in place if you're in that scenario where you can separate yourself from your loved ones, clean, separate your clothing, shower, or make sure that you have those pathways that you can at least disinfect yourself as best as possible before exposing those who are in the home to what you externally have brought in with you. And unfortunately, as I mentioned, the concern with the younger population getting this illness, we know that there have been babies who have come down with coronavirus, but we have not seen any negative, true negative outcomes within that population just yet. Not to say it doesn't exist, but we have not seen them being negatively impacted as the elderly and those with underlying medical conditions. And of course, if there's a baby with a medical condition, obviously they're at a higher risk as well. Yes, sir.
Thank you for doing the presentation, first and foremost. Secondly, I wanted to ask you, I believe just because based on our conversation, it sounds like things are constantly evolving on a regular basis.
Yes.
And so we don't have a baseline as far as how severe it can be. So with that being in mind, as of today, my office is now closed, and we're supposed to all work remote to prevent any further exposure for anybody that's international travel. And it started making me wonder, how should I prepare as far as buying supplies? Because it's very easy to buy like supplies for a week, but it's very difficult when you have an indeterminate amount of time. So if you had to come up with a recommendation, obviously it's based on the facts that you have around, but what would be a good way to prepare and for how long?
So what is presently recommended is at least looking at generating a 2-week supply. I would say go past 2 weeks for several reasons. And it's just me. In fact, I forgot to say the views that are expressed are not the views of the grandma. Have to get the caveat in there. So you try to prepare these food and supplies at least for a 2-week plus scenario. And I say that because I went out last weekend just to see how folks are like at a Costco, and people are like panic buying, but they're panic buying like salmon and beef, etc. And the question, well, are those perishables or not perishables? What if the power goes out? And then there's folks who are like, whatever, I can go to the corner store, I can go to the supermarket, the key food A and B, the Whole Foods, and get something. And the reason why I say go 2 weeks plus, because we may actually find ourselves dependent on if we go worst case scenario with an impact on our food supply. I mean, if you think about it, you just mentioned your office has essentially shut down and people have to be remote. What happens when the transportation industry, meaning those trucks that bring in food, or the food service industry, the individuals who stock, etc., if they become ill or if they are unable to work, or we're not able to provide emergency food supplies in a rapid fashion, as you can easily say, I'm just going to go to the store and buy something because it's New York and something is always open. So I always would say if you can develop a personal plan that allows you to at least provide provisions that can cover you for 2 weeks or 2 weeks plus, it at least gets you through at least the first phase of how long this a worst case scenario can present itself. Now, things may change and you don't want to turn yourself into a prepper that totally is now you got a whole ton of canned products that you're never going to eat. But the reality is you err on the side of caution and you try at least to plan plus to hopefully get you through the long run. Gentlemen in the back and the back to you.
So we know that at this point we know that coronavirus is pretty much more detrimental to the elderly community, right, with underlying conditions.
Yes.
However, I just want to say I worked in healthcare profession several years ago, and I was wearing scrubs, right? And I had came out the hospital and went across the street to get some lunch. Came back in. Just so happens the infectious disease administrator, registered nurse, seen me
And yell at you, right?
I came back in the hospital and she asked to see my ID. And I was like, well, who are you? And she's like, I'm an infectious disease, all that, right? And she told me it was a violation. It was a violation to leave out the hospital and go outside and come back in with those same scrubs on without taking them off. My concern is, you see a lot of people today, and I know a lot of the younger people, they're in healthcare, they go to school and whatnot, but you also have a lot of healthcare providers and people that work in the hospitals that work in these hospital institutions and nursing homes where it's particularly detrimental to our elderly. With the CDC, as opposed to washing their hands and using the hand sanitizer, coming out with a directive or edict or something to that nature as far as having these people change from these scrubs coming in and out of these hospitals and healthcare institutions.
So there is guidance on healthcare facilities and those individuals who work in a healthcare setting. There's very stringent infection control recommendations that, not just because of coronavirus 19, but something that has always been stressed by infection control professionals in our world. And I can tell you, I automatically knew when you started to describe that scenario what happened, because we see people all the time. You know, they go into work, they wear their scrubs, you know, they're nurse's aide, a nurse, whatever, and then they go into the healthcare center and they come out. In reality, that's one of the worst things that you can do, because you are the reason for wearing scrubs is to, one, be in a clothing that would minimize the ability to infect or to contaminate a relatively clean hospital setting. We also know that there's a rise in healthcare-associated infections, which also is tied to the antimicrobial resistance rise of infections that we've seen. So we always want to make sure that it is stressed that you shouldn't be going from a dirty environment into a clean environment, because you are introducing bacteria, viruses, and other pathogens to that clean scenario. So just as I was mentioning to Dan, what we would say for an individual who's going to a home setting, you should really try your best to ensure that you're not bringing things in and out. The same is expected for those in the healthcare setting. And that's why it's very important that folks don't necessarily just go wearing a scrub to work and expect that there's not going to be an issue when an infection control advisor sees you, but truly that you are thinking, how are you whole nation response, that you're not just thinking of like, I'm going to work and I'm in my outfit, and that there's nothing that I'm bringing in with me or bringing out, because that would be a false sense of security and a grave mistake with respect to how we view the need to have a strong infection control criteria in our country. Sir?
With respect to the test for the coronavirus that's been produced by the CDC, what is the margin of error or potential misdiagnosis of someone who presents themselves with these symptoms and associated with the coronavirus? And secondly, does the test definitively identify the virus itself to make a diagnosis of the person?
So it's a reverse transcriptase test, which you use basically to expel. The CDC test itself has shown a degree of 99% specificity, especially when you're symptomatic, which is one of the issues of why initially they did not want to do it on individuals that are asymptomatic, because when you have the virus, there were 99% capturing those individuals who were expressing it. The concern around false positives or false negatives was one of the reasons why you found the primary place of the emergency use authorization was in having it confirmed by CDC. When they sent the test out with the first set of reagents, the other labs started to try to validate the test for specificity and sensitivity, and found that one of the reagents was actually failing its validation test. So that's why the first wave of test kits that were sent were essentially scrapped, and then they went back to the drawing board and had to remanufacture new test kits, which have now made it into the hands of those 78 public health labs across the country. So to your question around how effective or specific it is, there is a high degree of specificity that the test does provide in detecting the virus, and with respect to ensuring that it is the actual virus itself. That's why the confirmatory tests are performed in those state labs that are validated and the CDC lab at this present moment, and why the commercial labs themselves have not necessarily been in that first wave, because with any commercial test, you also want to make sure that they have a validated test or a reference lab to validate their initial results. So those are all factors that play a role in how those test kits have been rolled out. More questions?
Much of the virus seems to be spreading in Africa. Could it be down to genetics?
Sorry, repeat the question, please.
Why doesn't the virus seem to be spreading in Africa?
It is spreading in Africa. It's in South Africa. It was identified in the Republic of Congo. There are several African nations that have detected and have seen the virus spread.
Okay, so that's
Yes.
how safe or risky is it to take a long plane journey?
Depends on where you're going. And depends on whether or not you have medical conditions or underlying concerns. So at this present moment, no one is saying that you can't have air travel. Of course, the air travel industry will like to get your business at rock bottom prices. But I would say it's the risk of exposure to an individual who is taking a long-term flight is one that you must also realize that this particular virus is not. When we saw the cases of infection based on an airplane or I would say an aircraft facility, one of the things that we were able to identify is that your risk of exposure to this virus in an enclosed plane usually extends to 2 rows in front of you, 2 rows behind you, and 2 rows on either side. It's not the entire plane that has been identified as a proper or a direct route of exposure. That's not to say if you're all the way in the back, you don't run the risk, but from the immediate cases that they have been able to identify through airplane travel, that has been the general premise of the understanding of how transmission can occur. Now, if you're there for a long period of time, you're moving up and down the aisle, obviously there's going to be risk associated. So that's the best I can answer to the question without necessarily knowing where you're going to, and of course, underlying conditions that may exist for those individuals who may be on that plane. Yes, sir.
Do you think this is an airborne transmissible virus?
Yes, it is.
Not droplet, but airborne, as a molecule.
Well, it doesn't stay in the air forever. So we've seen people sneeze, expel, and close proximity, and are able to essentially be exposed and develop illness. People who've been in cars, like for example, that one lawyer who has been the epicenter of the New Rochelle cases, he was in a car being transported, and individuals in the car were able to basically succumb to the illness. So that illustrates the efficacy of the airborne transmission route. The droplet precaution set is that, of course, it falls on the surface and an individual touches the surface in their face and their eyes, but it has very clearly been shown to have characteristics that are airborne.
The reason I ask is there's a possibility right on the boat that it was traveling through vents. Was one of the fears.
And that's one of the concerns with air handling. Now, not knowing the total ventilation system of those cruise ships, and if you recognize, at least with the most recent cruise ships, they were mostly the crew versus the passengers who were infected in the most recent scenario versus the first one where there were far more. Without real knowledge of what the air ventilation system is like, I would say it is one of the concerns that we have, when I say we, the public health community has, when we are looking to even establish quarantine or areas where there may be a common use, to ensure that there isn't an air handling system that increases the risk of spread rather than being self-contained.
And so follow-up question on the testing. South Korea has done 200,000 tests and is doing about 10,000 a day. We've done about 8,000 nationally so far. Do you know what the plans are for New York, state or city, as far as the near future? How many tests are in the
So
works?
New York has one of those labs, both the city and the state, that have been stood up with the capacity of doing their own tests. And as a result, I believe the governor has recently made some steps forward to get them more readily available in New York to be disseminated from New York. Plus the fact that there's a rapid approach to providing test kits to the general providers. The anticipation is within the next week or so that there will be more test kits available. And each test kit, from my understanding, has the capacity to test about 150 people. So just so you know that there's an exponential factor that is associated with the testing.
Okay, maybe let's have 1 or 2 final questions.
Yes, two really quick questions. One, are we seeing anything in terms of people being reinfected with the same strain, which we had heard in the early days? So people said they've been cleared but then reinfected in China. And the second is your presentation will be available online?
Sure. So reinfection is, we probably anticipate it's not necessarily reinfection, but maybe negative or false results in testing. Or even in some cases we've seen in real sense negative, and then it tests positive, as in one individual that was identified coming out of one of the areas that were quarantined from the ship. My slides are going to be available. I can make them available and provide them to my brother here to disseminate. But specifically, what we understand presently is that there is a degree of immunity that we understand does exist from having an infection, from being reinfected. The length of that time for that immunity is uncertain because we're still immune to the outbreak, but there's some learned immunity that does exist as a result of individuals who have resolved from the infection.
Feel free to skip it but I read in the Atlantic that part of the issue was testing had to do with privacy laws and the idea of doing testing in a clinical environment versus doing it in a different sort of environment. Frankly, I didn't read the entire article. I was just curious whether or not you have any idea of whether or not that's inhibiting our ability to conduct testing on a wider basis.
Not necessarily privacy laws, as long as the tests are being done by the clinical industry, meaning you're either just like you would get a script from a doctor. You can't just walk in and say, "Give me, this prescription." It has to be by the signature of a clinician. If the expectation is that individuals can do home tests, etc., that's not the priority at this present moment. Even though I know folks have put that out there, in reality, the testing is not the issues in testing is not related to privacy laws, but actually by making sure that the criteria for testing is met. And when I say the criteria, not meaning that it has to be strict, but that we have a mechanism that even if a clinical practitioner has the ability to test, that it has at least been communicated with the local health authority and the state health authority so that they can confirm and ensure that the individuals that are being tested meet at least the standard, whatever that minimum standard may be, so that we're not clogging the system and as a result not having the ability to test those who are mostly in need and are in dire straits, for lack of a better word. Thank you very much for your time and your questions.